It's truly a great honor to be here today. I was invited by a phone call from Nizar, who suddenly disappeared from this room. And I have two confessions to make before I make that, before I give this talk. I made two mistakes when Nizar spoke to me. I misheard him. I thought he said the top 10 papers, not the top 10 topics, which is quite different. And the second mistake I made is I didn't ask him how much time have I got. Until then, I got the pleasant surprise of seeing the program and seeing that I have 30 minutes to cover literally 10 topics. So in essence, this is 10 presentations in one. And what I'll try to do over the next 30 minutes or so is take you very much in a roller coaster ride. I think you'll feel dizzy at some point. What I'll have to do is spend roughly 2.5 minutes per topic. So please brace in. Our first story from last year has to be the one that started in this very nice city. A 60-year-old man walked into a private hospital with history of a productive cough, fever, and shortness of breath. He was started on very broad spectrum antibiotic regimen, including levofloxacin, tazocin, micafungin, and Tamiflu. 24 hours later, however, he did not improve and ended up actually in ICU. And the x-rays that you see there show the progression over those 24 hours. His antibiotics were later adjusted in response to various cultures that were obtained during his admission, but nevertheless the gentleman developed multi-organ failure and died 11 days later. The hospital carried out a lot of fascinating diagnostic work on the respiratory specimens that they had, including the indirect immunofluorescence and PCRs and cultures, and failed to identify any specific cause for this gentleman's illness. But among us, the beautiful things that they did was a cell culture for viruses. And the screen there shows you the cytopathic changes that were seen. They tested the patient's serum against those cell cultures, and they reacted very strongly. But when they went back to 2,000 plus sera that they had saved from previously, none of them reacted. And they realized straight away that there was an unknown antibody in this gentleman's serum. The samples were sent on then to the Netherlands in Rotterdam, where further identification was carried out. And what they found at the end was a novel human coronavirus that was named the Erasmus Medical Center virus, or the EMS as it stands for. Since then, further cases have occurred across the world, but mostly centered around the Arabian Peninsula. And the initial working diagnosis of someone with an undiagnosed respiratory disease or infection in Saudi Arabia has now been expanded to include the Arabian Peninsula and all Arabian countries. In other words, if you decide to present somewhere in the West with an undiagnosed respiratory illness and you happen to be from anywhere, novel coronavirus will be considered until proven otherwise. Now, the sad news as far as the novel coronavirus is concerned is that it seems to be mostly a very severe infection with indeed a very high rate of mortality. But the good news, if there is any here, is that it doesn't seem to be very transmissible. And so far, this virus has not succeeded in causing sustained transmission within a community. There are only 3 clusters so far, 2 of them in Riyadh and 1 centered in the United Kingdom, but it included someone who had visited Saudi Arabia and Pakistan just before. So our first story, and I hope I've managed to finish it in 2.5 minutes as I promised, is the novel coronavirus. Staying in with viruses, the next big story is to do with HIV. Now, a few years ago, studies in gay men showed that pre-exposure prophylaxis with Truvada, tenofovir, and emtricitabine can reduce the risk of transmission significantly. 3 studies were published simultaneously in the same issue of New England Journal of Medicine, 2nd of August last year, and they all looked at pre-exposure prophylaxis, or PrEP, in heterosexual individuals. The first one, the FEM-PrEP study, included 2,000 or more ladies who were given, obviously HIV-negative ladies, who were given a combination, that Truvada, to prevent HIV infection. The study, however, was terminated prematurely because of lack of efficacy and significant side effects. But just like everything in life, medication will only work if you take it. And using pill counting, the compliance was reported to be around 88%. But when they measured levels in blood, the compliance was actually only 40%. So this study essentially failed. But it may be that it failed because the ladies did not take Truvada as they were supposed to do. The second study was different. This is the, these two are out of sync, so I'm struggling to work out where am I in that. The second study was again, the setup was again in Africa, but this time they recruited 4,500 couples, serodiscordant couples, where one person would be HIV positive and the other person, the spouse or the partner, would be HIV negative. And again, the seronegative partner was given either Truvada or tenofovir alone. And then they were followed up with the endpoint being time to infection. And after 3 years of follow-up, there's been a significant reduction in HIV infection in the seronegative partner. This worked with a very, very high level of adherence. A third study, again set up in Africa, showed the same. Again, heterosexual couples given given Truvada versus placebo, and again showed significant reduction in infection. So the news here is that we can actually now prevent or reduce the risk of HIV infection using antiretroviral therapy. These studies were published in August, and in September, CDC have changed their guidelines and they are now recommending prophylaxis for in very certain situations. Now, if you were to apply this to our cohorts of patients and think about our serodiscordant couples who continue to be at risk of HIV, perhaps ladies who wish to conceive and are worried about becoming infected, or perhaps ladies who are less empowered to demand or insist on barrier use. I think for selected patients, PrEP seems to be a very, very good option. So that was your second story, PrEP. Sticking with HIV for one more, there are newer antiretroviral agents just about every day you hear about, just every other meeting you hear of one. And one of the exciting ones is elvitegravir. Now, it is very closely related to raltegravir, as you could guess from the name. And the simple difference is that it is co-formulated with copistat. Now, copistat is a ritonavir derivative. What it does is exactly what ritonavir does when it boosts protease inhibitors. It reduces the elvitegravir excretion and therefore boosts its pharmacokinetics, allowing once daily administration. Now, that is obviously very attractive. The second attractive part is that this is being co-formulated again with tenofovir and emtricitabine, giving us a 4 drugs, single tablet antiretroviral regimen. So this study made sense. Naive HIV-infected individuals were randomized to either a triplet, that's a single agent, single tablet combination antiretroviral therapy, versus quad, as it is now known. The endpoint being percentage undetectable after 48 weeks. And it showed non-inferiority with very, very high level of tolerance to the study medication, with an exception which I'll come to in a second. There was a second study that again compared the quad, but this time with a atazanavir-based antiretroviral regimen, again showing non-inferiority. The key thing to take away from all this is that the safety was generally good, except there are still some concerns about the renal function. What copistat does is it inhibits the tubular excretion of creatinine. Now that results in higher serum creatinine levels and a spuriously reduced GFR. If you were to estimate GFR using the serum creatinine, you might end up underestimating the person's genuine glomerular filtration rate. However, because at least 4 patients developed Fanconi syndrome in the 2 studies, the regulators have insisted that the randomization continues to 192 weeks to obtain enough data about the renal toxicity. The other issue with elvitegravir, again, is because of the copistat, it has lots of drug-drug interactions. But the bottom line is, we here now have a second single tablet combination antiretroviral regimen that may well be useful for many of our patients. There's another study which I wouldn't show you here in Lancet Infectious Diseases that looked at experienced patients, and again, the results were interesting. Finish with HIV now, but still with viruses. Now, hepatitis B causes lots and lots of morbidity across the world, including, obviously, our part of the world here. And the story of controlling hepatitis B perhaps dates back to the 80s when the vaccine was introduced. Lamivudine was introduced in the 90s, and that gave us some encouraging results, but then the resistance emerged and the treatment eventually failed. Dalbivudine was really a never good starter. And eventually, around sort of the middle of the first decade of this century, we got the big two breaks, entecavir and tenofovir. Now, entecavir has the distinct advantage of a high genetic barrier allowing prolonged treatment. And the first endpoint, the usual endpoints of viral suppression, were for the first time replaced by histological improvement with this study. Again, it's an old study. This is not your new story. But it was a small study, 57 plus patients. But it was the first to show that you can actually reverse fibrosis and improve cirrhosis in patients who have chronic hepatitis B infection. This was a small study. But this is a brilliant study. And this was reported in February this year. Here, Patrice Marcelin in Paris and his colleagues recruited patients many years ago for tenofovir versus the defivir. But the study design allowed that patients can select to go into an open phase and continue follow-up for 7 years. Now, what is most impressive about this study is not that. What is most impressive is that they managed to get pairs of liver biopsies at start and 5 years later for almost half of the patients. So what you're looking at now are results of 350 patients after 5 years of tenofovir. What are we going to see? Now, when you're assessing liver histology, one of the things that are very useful is to be objective and use a score. And one of the common ones is ISHAC, although the paper reports NODEL as well, if that's what you're more used to. And essentially, I'm becoming very confused. I don't know where to, I'll look this way this time. Essentially, what you want is as low a value as possible. An ISHAC score of 0 means no changes. An ISHAC score of 1, 2, or 3, or 4 indicates increasing inflammation, and 6 indicates cirrhosis. And what you will see when you compare what's going on here before and after 5 years of therapy is that the colors have switched around. A significant, a very, very high proportion of patients have less fibrosis. 75% of those who were cirrhotic managed to reverse that. So for the first time, we have conclusive evidence that you can actually reverse the wheel. You can take the time back for hepatitis B. And I, for one, think this is a brilliant story. I told you it's a roller coaster, and that's where we are now. Okay. Finish with viruses. What about our day-to-day Staph aureus? We see quite a lot of that. Now, MRSA has been a problem. And vancomycin has been our savior for a very long time. But as you all know, a few years ago, reports started to emerge that with the MIC creep in MRSA, vancomycin seems to be less and less efficacious. But those reports were not always consistent. So what those authors from Sydney set out to do is a systematic review using Cochrane methodology. And they reviewed all the existing studies that looked at the relationship between an MRSA's MIC against vancomycin and mortality and clinical response to treatment. They screened lots of studies and ended up with 25 high-quality studies that tested this very question. And what they found was this. If you look at MRSAs with a vancomycin MIC of 1.5 or more, here described as isolates with higher MIC, versus those that have MICs of less than that, you will see that mortality or the risk of mortality in those with a higher MIC is higher. And that is the bottom line figure that you get from looking at these sorts of graphs. Looking at clinical response, you get the same. Now, the reason that the ID physicians amongst you and the microbiologists amongst you will be very concerned when they hear this is that you will know that the break point for vancomycin was reduced from 4 to 2 to try to take in these stories of reduced clinical responses and increased mortality. If, for some reason, the break point is to be reduced to 1.5, you're going to have to be thinking long and hard about what is that you're going to use for your patients with MICs or with MRSAs with an MIC of 1.5 or so. The same authors also wrote this brilliant review, which I strongly recommend to you, looking at predictors of mortality in Staph aureus bacteremia. And after looking at all the evidence, they show very clearly, and as I said, it's a brilliant paper that I very much recommend to you, that obviously MRSA versus MSSA increases the risk of mortality, but also they show or collect the evidence that shows that vancomycin and beta-lactam, beta-lactamase inhibitor combinations for MSSA are associated with increased mortality compared with fluclox. There are other predictors, including the lack of an ID consult and various other things, but I only have time to say that. The other bacteriology story was the azithromycin. Now, in our hospital, our treatment recommendation for community-acquired pneumonia, moderate to severe, is a beta-lactam plus azithromycin. And what these investigators did is they took advantage of this brilliant electronic record of the Tennessee Medicaid. Now, that allowed them to examine hundreds of thousands of medical records that were linked to discharge summaries and death certificates. And what they did is they looked at azithromycin prescriptions, well, more than 350,000 of them, and controlled for that with literally millions of patients who did not receive any antibiotics or received amoxicillin or levofloxacin or ciprofloxacin. Now, azithromycin was associated with tachyarrhythmias, irregularities in heart rhythm, including the risk of sudden death. And what they did is they looked at the increased risk of mortality associated with azithromycin for the first 5 days, because azithromycin is usually prescribed for only 5 days. And this is brilliant. Look at what they found. Now, comparing those who've received azithromycin versus nothing, there was a significant risk of sudden death, cardiovascular death, and all deaths in the first 5 days. But that difference disappeared if you look at the next 5 days. Now, that's compared to patients who did not receive any antibiotics. The question is, what if there were confounders? What if those patients received antibiotics because they're sicker? There's a lot of detail that we can go into if we only had time, but we don't. So the next thing they did, is they looked at the same, but comparing those who received azithromycin versus amoxicillin, and the difference stood. If you take an average patient from that record, you had 2 to 3 times higher chance of dying if you were to receive azithromycin compared to no antibiotics or to amoxicillin. Now, they also wanted to make sure that this was not somehow a statistical flaw. So they looked at levofloxacin, which was also associated with these risks, and they found no statistically significant difference. The other interesting point to make is this. When you stratify patients by their cardiovascular risk, you find that the increased mortality increases substantially with those with increased cardiovascular risk to start with. So in other words, use azithromycin if you wish, but perhaps you need to be very careful if you have a patient with a higher cardiovascular risk. These graphs are just to show you that this did not happen with levofloxacin or ciprofloxacin. Mind if I take your water? Yeah. I'm giving you a break as well. Now, we wouldn't give you 10 stories and not include a single one fungi. And voriconazole has been around for a while. And many, many years ago, studies started to emerge that suggested that voriconazole levels were very difficult to predict based on dosing. And this study, for example, from Pasquale in Paris again, shows that for a range of vancomycin, for voriconazole doses, you get various voriconazole trough levels that are sometimes difficult to predict. And these investigators, as well as others, have managed to show an association between low levels of voriconazole and lack of response, and also showed an association with higher levels of voriconazole and toxicity. But these were this is a retrospective study. And then a second retrospective study, again from Sydney, showed the same, that the voriconazole levels vary greatly from one person to another person using the same regimen. Not just that. This graph shows you the variation within the same individual. So now we know that voriconazole level change or vary significantly between patients and within the same patient. And the same question rises again. Is that associated somehow to clinical response or toxicity? Now, those retrospective studies suggested yes, but another retrospective studies said no. So what is the story? The story is that for the first time ever, we have a randomized prospective study that looked at exactly this question. How would patients who have their voriconazole levels checked and maintained at the target of 1 to 5.5, how would they fare compared to patients who were given standard doses of voriconazole if they had all invasive fungal infections? Now, this brilliant study from South Korea did exactly that. And what did they find? Now, the rate of side effects in the two groups were the same. But those who had their voriconazole levels checked regularly had a significantly lesser chance of stopping the medication. In other words, the side effects were not as severe if you were to monitor the levels. Not just that. If you look at clinical response, again, those who had their levels checked did better. Now, the difference between this study and all the others, as I said, is that this is a randomized prospective study. And now the question becomes very, very real. Should we be now measuring voriconazole levels in all our patients? And if we do, then does that end the discussions around whether we should be doing it or not? My previous speaker talked about TB, and when you do these sorts of things, you end up always encroaching in everyone else's, but at least he saved me some time by identifying or giving you a definition for MDR and XDR. But this CDC study was different from everything else you've seen before. Because what they did is they recruited patients from 9 countries and submitted all the samples to the CDC lab to confirm that those isolates were resistant and is resistant to exactly what. They also collected very comprehensive epidemiological and clinical data to try to correlate risk factors for MDR and XDR TB. They recruited patients from 9 countries, but they only include 8 in the table because they didn't receive the isolates from Taiwan. And the things to point out are this. Don't acquire TB in Eastern Europe. Because if you do, if you look at here, 50% of those who have MDR TB in Estonia never had TB before. In other words, these patients acquired MDR TB. Now, that's half of your patients. That's scary. Looking down now, if I had a patient with MDR TB that I would like to treat, I would certainly look at quinolones, and I would look for an injectable aminoglycoside. I'll look at this table. The resistance rates to fluoroquinolones and to injectable aminoglycosides, it's just simply scary. And again, whatever you do, make sure you don't acquire TB in South Korea by the looks of it, because 15% of it is XDR. So the bottom line is, just like Dr. Bahar said, MDR and XDR seems to be increasing. And that's a very sinking story. But the slightly uplifting story is that perhaps we have newer options now to treat MDR and XDR TB. Delaminid, it's a newer antituberculous agent. It inhibits mycolic acid synthesis in mycobacteria, and it showed in vitro and in vivo results that were encouraging. But this is a randomized prospective study in patients with MDR tuberculosis. And they were randomized, the patients were randomized, they all received optimized WHO guideline-based background therapy. And then they were randomized to either a placebo or 2 different doses of Delaminid. And after a follow-up period, there was a significant improvement as measured by culture conversion. These patients, well, the definitions demanded that the patient must have 5 negative cultures to be called a culture conversion. And that's what they achieved with a relatively high safety margin. The second option that you might not have, or you've had for a while but did not know enough about, is linezolid. Now, linezolid, as you probably know, has significant antimycobacterial activity, and we have been using it in our clinics. But the initial data, the licensing data, obviously only included patients who were treated for 2 weeks, and we only knew side effects that were relevant to linezolid for 2 weeks. But as we started to use it for longer and longer, newer side effects emerged. Now, what this study does, it looks at 41 patients with XDR TB who were randomized as follows. Those 40 patients were randomized into either receiving linezolid in addition to their background therapy immediately, or to receive the linezolid 2 months later. So the immediate start versus the delayed start, because you can't deny patients linezolid. And as you can see in the graph, significantly more patients who had the earlier start of linezolid achieved the endpoint of sputum culture conversion. After 4 months, the patients were randomized again to either a lower dose of linezolid, 300 milligrams daily, or to continue on 600 milligrams daily. 2 things to show you. The first is linezolid improves response substantially. The second story, the longer you use linezolid, the more you are likely to develop side effects. And as you can see here, as time went by, more and more people developed peripheral neuropathy, optic neuropathy, myelosuppression. But if you were to use the 300 milligram once daily rather than the 600 milligram once daily, you are significantly less likely to develop those side effects. So we have more and more MDR and XDR TB, but perhaps at least we have some hope with some newer agents and perhaps a better understanding of how we could use linezolid a little better. Okay, I have 3 more minutes left. Infection control. Now, infections in critical care, in ICUs, have always been a concern for everyone. Line-associated infections in particular, CLABSI, central line-associated bloodstream infection, as the new term now. And we all know that by doing basic things very well, we can reduce those rates of infections substantially. Provenist, his colleagues in Michigan and elsewhere have shown that conclusively. But what you could do is reduce your CLABSI rates from there to there. But can you actually make them 0? Now, in order to make them 0, you're going to have to do a little more than that. And perhaps you will use antibiotic impregnated lines or coated lines or sponges with chlorhexidine, whatever you do. 1 minute? That's fine. I'll do it in 1 minute. Here, these patients were bathed with chlorhexidine, and that was associated with a significant risk reduction of colonization and infection. The last story, and I'll do that in a minute, is mass gathering. This is a very interesting paper that was written by Ziad Maimish and his colleagues in Lancet Infectious Diseases. And what it does is it tries to share the lessons from Hajj with everyone else. And what are the implications, the healthcare provision indications of such a massive gathering of people in one place in one time. And if you look at graphs of bigger events across the world, you'll see that Hajj fairs there. It's a huge event, we all know that. 3 million, 4 million, 5 million people there. But it's not the biggest. This, for example, is an event that happens 3 times a year in Manila, in Philippines. They celebrate the Black Nazarene, where they carry a life-size statue of Jesus across the city. It's attended by 9 to 10 million in one day, the process across the city. This is an even bigger event. It happens in India. Last year, or actually this year, it was attended by 90 million individuals who all wanted to be in this place and wanted to swim and bathe in this sacred water that they believe that somehow washed away their sins. The takeaway message is that these big crowds do have their own healthcare needs, and they do need to be cared for in a certain way. It is a roller coaster, so I don't think there's another way of doing it, and I hope I've managed to do it in time. Thank you.